Hello and welcome to Live Healthy West Virginia, the podcast brought to you by WVU Medicine, aimed at helping everyone live a better, healthier life in West Virginia and beyond. I'm your host, Mary Ravazio Menard. March is Colorectal Cancer Awareness Month. Colorectal cancer is the second deadliest cancer in the U.S., yet it's highly preventable with screening. Even more troubling is a recent American Cancer Society study in the U.S. that found that while colorectal cancer is decreasing in those over 50, it's surging in those under 50. What's causing this and what can be done about it? How can you prevent colorectal cancer? We'll answer those questions and more as we're talking with Dr. Shyam Thakkar, Director of Advanced Therapeutic Endoscopy at WVU Medicine. Welcome, Dr. Thakkar, to Live Healthy West Virginia.
Thank you for having me. It's exciting to be here. Really appreciate everything that you're doing to help our patient population. And it's great to share the passion we have around colorectal cancer with you and the entire population.
That's great. Thank you. It's good to have you here. So let's start with the basics. What is colorectal cancer?
Yeah, so colorectal cancer refers to cancers that arise in the colon or the rectum, okay? It's a growth, essentially, that happens over time and can potentially threaten a patient's life because it turns into it is a cancer. It originally starts as a polyp, which is a small growth from the lining of the colon, and over time that growth continues to advance, it can turn into a cancer and metastasize to other organs. We usually believe that a polyp takes about 7 years to turn into a cancer. So by finding polyps, removing them, we can effectively prevent colon cancer from happening. But if we don't, then certainly that's a big risk.
How common is colorectal cancer?
So colorectal cancer is fairly common. I mean, it is one of the most common causes of cancer in the United States. I believe it's the fourth most common cancer, but it's the second leading cancer deaths in the United States. About 150,000 people are diagnosed with it annually. And so you know, it's with over 50,000 deaths from it annually. So it's definitely a very worrisome disease.
You did mention that it's the second deadliest cancer, but it's highly preventable with screening.
That's right.
So what's the best way to screen for colorectal cancer?
Well, we have several methods of screening, but the best method is colonoscopy. Colonoscopy involves essentially using an endoscope, a flexible tube with a light at the tip, a camera at the tip, that we insert from the anal canal through the rectum all the way to the beginning part of the colon, which is the cecum. We then inspect the lining of the colon, and as we're inspecting it on the withdrawal phase, we look for any polyps or lesions or early tumors, and if we find them, we can either remove them or at least take biopsies and make a diagnosis, hopefully, of an early lesion so that it doesn't turn into a problem later on for the patient. When it comes to why I say colonoscopy is the best screening method, when it comes to our screening methods, we have that. We have a Cologuard test. We have fecal cold blood testing. But you know, of all these different types of tests, the colonoscopy is the best test because it's the only test you can screen, diagnose, and treat all at once.
I think that the Cologuard test has become more popular, it seems, in recent years. Now, is that as effective, though? I mean, like colonoscopy is the gold standard, right? I mean, how effective is Cologuard?
Again, colonoscopy is the gold standard because it's the only test you can screen, diagnose, and treat all at once, right? We can find it, polyp, we can remove it, make that diagnosis of a polyp and remove it. And so patient has essentially had their cancer risk eliminated, you know, before it turns into a cancer. Cologuard is a good test. What Cologuard offers is basically a combination of what we call fecal cold blood testing. So essentially, it looks for blood in the colon. It also measures stool DNA. So it looks for any DNA in the stool that's suggestive of an early colon cancer. Okay. Now, what Cologuard is good at is helping us diagnose early colon cancers in patients. It has a fairly high sensitivity for that. But what it's not good at is diagnosing polyps, the precursor lesions to turn into cancer. So if a patient has a polyp, it's not very good at telling us that there's potentially a polyp and this patient needs a colonoscopy. But if it's positive, it's worrisome that the patient may have a cancer, so the patient needs a colonoscopy to get a biopsy. So it doesn't do anything to really prevent colon cancer from happening.
Right.
So if you're not going to get a colonoscopy, then at least get a Cologuard test, because some form of screening is better than no form of screening, but the best test is a colonoscopy.
Yeah, I had the feeling that's what was the reason, to catch those people that just wouldn't do it at all.
Right. Right.
Yeah. Now, they recently lowered the age
That's
to start for screening for colorectal cancer. It used to be 50, now it's 45.
That's right.
Why'd they do that?
That's right. So there's been an increasing incidence of colon cancer in the young. And that's been part of the driving factor to start screening at an earlier age. And it's not really clear why we're seeing this increasing likelihood of having increasing trend, I shouldn't say likelihood, but increasing trend of early colon cancer. And when I say early, before the age of 50, okay?
Yeah.
And so, but what we've seen, we did actually a study on looking at some of the risk factors for early colorectal cancer, and the age where seems to be the decade where there seems to be the highest predominance before age 50 is the age 40 to 50, not surprisingly. So appropriately 45, I think, is a good start to this. What are the risk factors? Why is this happening?
Yeah.
Some of the reasons are diet, Western diet, processed foods can certainly put us at risk, not eating whole foods. Red meats can put us at risk. Smoking, obesity, lack of physical activity, all these things are risk factors for the development of early colorectal cancer. And colorectal cancer in general.
I bet you see a lot of that in West Virginia, because we're so high up in
some of these
all
things.
those
Yes.
things.
Yes.
Well, not them all, but
yes.
a lot
But
of
the
them.
good thing is patients understand now that screening ages are lower. And the other thing to understand is genetics, right? If you have a family history of colon cancer or a family history of colon polyps, someone that was affected with colon cancer at age 48 or 51, screening starts earlier, at least 10 years earlier, or at the age of 40, whichever would come first in that instance. But that's part of the reason why we start screening at earlier ages now. And if there's no family history, no genetic risk factors, then yes, starting at age 45 is critically important to ensure that we can remove the precursor lesions so that these patients don't develop colorectal cancer later on as well.
Okay.
Yeah.
They're predicting that colorectal cancer will be the leading cause of cancer death for people between the ages of 20 and 49 by the year 2030. That's just 5 years away.
Yes, it is.
That's a big deal, isn't it?
That is a big deal, but we're trying to take steps to help minimize that. So, one of the things that we do now in colonoscopy, we have it's becoming more and more mainstream across the country. It's not available everywhere, but we have it here at WVU, is using artificial intelligence in colonoscopy. So using AI to help us during screening exams, identify polyps. If we find them, we in effect remove them and prevent that colon cancer from happening well before that patient develops colon cancer. But it helps us increase our detection of polyps, so that the last thing we want is for someone to undergo screening colonoscopy and miss something that could potentially turn into cancer later, So AI is playing a big role.
And that's standard procedure here, isn't it?
That's right. That's right.
And it's like having an extra set of really smart eyes, right?
That's right. That's right. That's right.
That's great.
Yeah.
That's great. What is the general survival rate of colorectal cancer right now?
So when it comes to the survival rate for colon cancer, with treatment, patients can do well, okay? And this goes across various stages. But the new chemotherapies, the new surgical interventions all have tremendous impact on their outcomes. And we're seeing survival increase with respect to the different stages. So it depends on the stage 1, stage 2, stage 3, stage 4. But at early stages, patients can do extremely well. Even later stages, we're seeing patients that go 3 years, 5 years, continuing to do well because of the advent of new chemotherapies and the tumor biology response to those chemotherapies.
Is the rate of screening going up? I mean, is there more awareness, or do we have a lot of work to do with that?
We still have some work to do with that. And, I think, one of the problems we have or we suffer with when it comes to screening is that we're only screening about 60 to 65% of the population right now. We really want to screen 100%. There's no reason why anyone shouldn't get a screening colonoscopy. And it's 100% covered by the Affordable Care Act. So there's no, co-payment for that procedure itself. Now with the various preps, there's always a prep that's typically covered under the insurance.
Sure.
There are better preps than others in terms of the types of preps that are lower in volume and as effective compared to the larger volume preps. Depending on the insurance, some may be covered, some may not be. But at WVU Medicine, we've partnered with an organization so that worst case scenario, if a patient wants the preferred prep, worst case scenario, they would pay no more than $50 for that.
Oh, wow.
Or they would therapeutically interchange to whatever prep there is reasonable for them or is covered by their insurance completely, whatever kind of the patient is wanting to have. So we're trying to make that piece of things much easier on patients as well.
Okay, so give us a little checklist of symptoms for colorectal cancer.
So the most common symptom for colon cancer is no symptom at all, completely asymptomatic. Yeah,
great.
Yeah. But other symptoms that we can have with colon cancer include bleeding, include unintentional weight loss, include diarrhea, include constipation, include pencil-thin stools, change in bowel habits, abdominal pain. But again, some of these are very, generic, and asymptomatic is kind of the most common symptom. In other words, no symptom at all. That's why screening for colon cancer is so important.
Should you get screened earlier if you have a family history,
Yes.
earlier than 45?
Depends upon when that family history is. So if it's someone in the family that was affected with colon cancer under the age of 60, but over the age of 50, then yes, screening should start at age 40. If it's someone that was affected, at the age of 43, then a first-degree relative, then colon cancer screening should occur at least 10 years before that, so beginning at age 33.
Okay, and can you give us a little checklist of risk factors that make us more likely to get colorectal cancer?
Yeah, diets high in red meats are a risk factor. Obesity is a risk factor. Physical inactivity is a risk factor.
Smoking
Is a risk factor.
Causes everything.
Heavy alcohol smoking is a risk factor. Heavy alcohol consumption is a risk factor. And then of course family history is a risk factor.
Yeah, it's common sense almost, right?
Yeah.
So what steps can people take right now?
And one other factor, inflammatory bowel disease, a history of inflammatory bowel disease. If you have Crohn's disease or ulcerative colitis, that's also a risk factor.
Oh, okay.
Yeah.
So what can we do right now to, prevent colorectal cancer?
Yeah. So, from a diet standpoint, certainly diets high in fruits and vegetables will be protective. Minimizing or, everything in moderation when it comes to red meats, avoiding heavy alcohol consumption, avoiding tobacco, staying physically fit and exercising regularly, these will all be things that are protective to the colon, okay? Knowing your family history, knowing if you have any genetic predisposition, if you have cancer syndrome in the family, that's something important to talk to your doctor about. And then, of course, undergoing screening when your age is appropriate, having that conversation with your primary care provider sooner rather than later, whether in your 20s, 30s, or early 40s, even 50s, it's still not too late to have the conversation. Hey, doc, is it time for me to have my colonoscopy?
Yeah.
Or what do I need to do for colon cancer screening?
Right.
Yeah.
Well, we've talked about the importance of screening, but if you are diagnosed, what are your treatment options?
So if you are diagnosed with colon cancer, okay, so there are several options, okay? So first and foremost, colon cancer kind of falls into these various stages, early stage, later stages as well. But also, when we have these polyps that grow, they can sometimes be larger polyps. Some of the things we can do in endoscopy is called endoscopic resection of these polyps. So with that, what we can do is essentially remove these polyps endoscopically if they're larger polyps, but they might be early cancers, but have not invaded through the wall of the colon.
And can you remind us again how endoscopy works?
Yes. So again, it's the flexible tube with the camera at the tip of the scope that we insert. We identify the polyps. We raise and lift them from the wall of the colon by injecting some saline with some additional solution to it to allow the polyp to essentially lift from the muscle layer, and then we resect it completely using snares or various needle type knives to carve it from the wall of the colon or the rectum. And this can work very well for patients. Now, if it's more advanced, then certainly we're talking about perhaps giving the patient some chemotherapy or allowing the surgeons to laparoscopically resect that segment of colon. So it might be a few inches or a portion of the colon, maybe half the colon that gets resected. In some cases, it might be the full colon, but then a reconnection is made between the small intestines and the rectum, unless, of course, the rectum is involved. So that being described is that there are surgical and endoscopic options to remove these tumors.
And I imagine if you do this endoscopically, that your recovery is shorter, is there less pain? Because I don't want to say it's not minimally invasive, right? But it's better than open surgery. Am I?
Yeah, if you do it, yes, absolutely. If you do it endoscopic, really, I mean, the patients may have some gas or discomfort following the procedure, but oftentimes we send these patients home the same day. Wow. It's rare for us to keep the patient overnight, from these types of resections.
Any other treatments we need to be aware of?
And then, of course, the chemotherapies. Okay. Those are continuing to evolve, and the cancer specialists really offer those to treat the advanced stages, even metastatic disease, so as to minimize the risk of progression or to put that tumor into remission.
Has there been a lot of progress in the chemotherapy treatments? Are they getting better?
Yes, there has. And I don't want to speak too much on the behalf of our oncologists because they are lights out experts in this field.
Sure.
But I can tell you, this is part of the reason why we've seen the survival of patients with colorectal cancer continuing to improve year upon year upon year.
Well, you mentioned the oncologist, so let's talk a little bit about the expertise of the team at WVU Medicine in detecting and treating colorectal cancer.
So we have a multidisciplinary team that includes medical oncologists, that includes colorectal surgeons, that includes advanced endoscopists like myself, that includes a general gastroenterologist who do a lot of the screening work and may even do some endoscopic mucosal resections, the type of resections that we talked about a little bit earlier. And then also we have our radiologists who are critically important in helping us understand through cross-sectional imaging how much or how far things could be involved.
Okay, so with this being Colorectal Cancer Awareness Month, what's the most important thing you want our viewers or listeners to know about colorectal cancer?
Get screened. 100%. That's the most important thing. It's that simple. This is a completely preventable disease, and it's so important for individuals to get that screening done. Ideally with a colonoscopy, but if not, through a Cologuard or through a fecal cord blood testing, get some form of screening done, because this is just so important to continue your longevity, continue to enjoy your families, continue to enjoy your job, continue to enjoy your children, your grandchildren, or your spouse or your significant others, and everything that you do in life. So get screened.
And it's not that bad.
No.
It's not.
I'll let you in on a secret. When I did mine, I didn't even use anesthesia. I was awake the whole time.
Oh, gosh.
Yeah.
Well,
Look at her reaction.
I didn't do that, no. No.
But really,
knock me out.
If I can do it without anesthesia, I promise you can do it with anesthesia. No, we routinely sedate our patients for colonoscopy. But just to tell you, I mean, it's not. There is
Okay.
not much discomfort that's associated with
Okay.
it. It's mainly just gas after the procedure.
Okay.
Yeah.
All right. On that
You can
note,
edit that out if you want.
No. We're going to leave it all in.
Okay.
No, but thank you so much for sharing this information. And, hopefully we're going to get a lot more people getting screened earlier so it's so easily preventable. Get screened.
100%. Get screened.
Get screened. All right. So that brings us to the end of this edition of Live Healthy West Virginia. If you're looking for more information about colorectal cancer or other cancers, visit wvumedicine.org/cancer. And to find the latest episode and all episodes of Live Healthy West Virginia, visit wvmetronews.com/podcast or the new Metro News TV app. I'm Mary Ravazio Menard, and on behalf of Dr. Thakkar and everybody here at WVU Medicine, thanks for joining us.